Welcome everyone. You're listening to the ICCA India podcast. Through the podcast series, we hope to bring out multidisciplinary dialogues by discussing the intersections of economics, policy, and cancer.
Welcome everyone. My name is Smitha Srinivas. I'm the India Research Lead of the Innovation for Cancer Care in Africa Project. It is my great pleasure with my team to welcome Professor Maureen Mackintosh today for a discussion about the ICCA Project. Maureen Mackintosh is Professor of Economics at the Open University in the United Kingdom. She is also the primary investigator of a very large team of which we are a part. And we're hoping today to have a discussion of the different aspects of this quite large, very interesting and mixed team research across the globe. Maureen, welcome.
Peter, thanks very much. It's a pleasure.
So I wanted to kick off today by asking you a little bit about the path that led you here in terms of research. What were the precursors in terms of research to the ICCA project, and what would you like to share with us?
I think the trajectory that's led up to this research is quite interesting. Probably the most important pieces of background were two pieces of earlier research, both of them collaborative with African colleagues. One was a project done around 2010, 11, 12, which was on access to medicines. And it was done with Tanzanian colleagues. And one of the things that led us to understand was the scale of the failures around access to medicines for a whole range of absolutely basic generic medicines, which weren't covered by the large global health initiatives on malaria, TB, and HIV. So that although there'd been an enormous and extremely welcome pouring of funding, really successfully, in particularly into HIV and TB medicines, the rest of the gamut of essential generic medicines, really access had not been improving. And one of the things that emerged from that project, which also involved some Indian colleagues working with us, was that it was clear that local firms were quite important in the access to medicines that did exist. So that basic medication for a whole range, for example, of childhood illnesses and so on, like anti-worm medication, for example, were being produced locally. And one of the things we demonstrated was that local firms were much more likely than importers to get medicines into rural areas. So we thought that was interesting. So that was one piece of work. The other piece of work was an earlier project which was specifically on local production of medicines and other supplies. And that was done in both Kenya and Tanzania and was a follow-up to that Access to Medicines project. And there we were specifically looking at whether local manufacturing was important to healthcare, medicines access, and whether there were synergies that could be exploited that hadn't been exploited between local manufacturing and health. And we emerged with a series of arguments about the scope for developmental synergies between industrial production on the one hand locally, in pharmaceuticals in particular, and potentially better healthcare in Kenya and Tanzania.
Tell us a little bit about the Making Medicines in Africa book that came out of this. I, of course, played a small role, but there was such a huge range of collaborators and others. And you had invited me to the project, and we were trying to find a way in which not just Indian and African researchers, but so many who were trying to build bridges. They were at this meeting. It was an exciting workshop. How did we go from there to the ICCA project?
I think it's an interesting story, partly because it's such a collaborative one across all kinds of boundaries. When we invited you to that, we were drawing by that time on your book on market menagerie, which was one of the few books at the time, I realize it goes back to 2012, one of the few books at the time that tried to look at the relationship between industry and health in real detail. And the thing that I remember that we liked about it really early on was that it looked at historical trajectories. That instead of the sort of cross-sectional work that we'd on the whole been doing, this drew on industrial economics, and it looked at historical trajectories, and it looked very impressively at the ways in which there'd been a divergence between the trajectories of health and industry. And we were very struck by that. And we had also, I and a number of colleagues, been working with Brazilian colleagues. Paula Tibande-Bage, my long-term, much lamented Tanzanian colleague, she and I and others had gone to Brazil and talked through industry health relationships with the Brazilians, who of course have been thinking about this for years and years. Their notion of the health industrial complex was another input to that previous research. So that by the time we got to 2015 and that workshop for making medicines in Africa, we had a network of people who were interested in the relationship between health and industry, and you were absolutely one of the intellectual progenitors of that. So the workshop was, as you know, an attempt to put a book together focused on the issue of making medicines in Africa, but bringing together people wider than East Africa, across Africa, and from Brazil and from India and from European countries to look at that issue, to use the work that we'd already done to generate chapters of the book, but also to try to get on the map the idea that we had to stop looking at health and industry in two separate silos, as we've often called them.
Now, the Making Medicines in Africa book was an extraordinary venture that came out of this intellectual exchange. And if I understand it correctly, one of really record-breaking in terms of how it's been accessed. Could you tell us a little bit about this?
Yes, that's been nice. It was done, Geoffrey Banda and I really wanted to do that as an open access book. And we discovered that open access books were a bit of a new idea, really, that what we had was a situation where open access articles were more and more accepted. But open access books were really quite new. This was 2015 when we were looking at it. And we had to raise funds because to do an open access book, you have to pay the publisher, of course, because it's then free. No one's going to pay for access to it. And we talked to Palgrave Macmillan, who had a series, An International Political Economy, which we felt the book would fit into. And the then editor of that series for Palgrave, Christina Brown, was very keen on the idea. And she came, if you recall, to the workshop for one day and met the authors and became even more keen on the idea. So we raised the funding and we did the book as open access. And it was the very first one that prestigious series had done in that form. And it was therefore put onto the web and onto the publisher's website as an open access book. And it's had 87,000 downloads to date. And the publishers were astonished. And since then, I've been doing talks for them about why open access is a good idea. Yeah. And it's become clear, particularly Jeff Banda, I think, has become very aware of the extent to which this has facilitated African readership. You know, in an absence of widely available libraries, books, bookshops, all of these things across the sub-Saharan African subcontinent, people have been downloading and using this book, and it's included manufacturers, NGOs, interested academics, huge numbers of students. So, yes, it was an open access book, which was a bit pioneering, and we're proud of that.
The African researchers, particularly, many of whom were involved in the Making Medicines in Africa book, were not only coming up, I remember, with incredible insights about the kinds of challenges they were facing, which were very different across the continent, but that process led us to the conversation today, which is on the ICCA Project, the Innovation for Cancer Care in Africa Project. How did we get here?
I think one of the things that's interesting about the African colleagues' experience at that moment was that it really was also a moment, perhaps rather surprisingly, when industrialization had got really back onto the African policy agenda. And a number of organizations were picking up the importance of the health industries, pharmaceuticals, health supplies, and so on. I'll call them the health industries. We're picking up the importance of that simply as an element of industrialization, as well as a potentially important issue for healthcare. So that the African Union, for example, was very much pushing the importance of this. Regulators for NEPAD were picking up this issue and making sense of it. In both Tanzania and Kenya, policymakers were picking up this issue. So this was a moment, really, when those African colleagues started to have policymakers' ears on this issue. So I remember looking back at that workshop, we've talked about that. We talked about these emerging networks, which a number of our African colleagues, including Julius Magwagwa and Jeffrey Banda, have been very much involved in developing. There's a current very important such network, for example, around vaccines in Africa. And that built on some of these much earlier initiatives. So they were already seeing that they had the policymakers' ears potentially. And they also had a lot of manufacturers and manufacturers associations that were expressing interest in actually using this research. Just developing a more detailed, perhaps more sort of empirically focused piece of work on exactly what we were talking about, if you like, how to do it. And I remember that it was our Kenyan colleagues, specifically Mercy and Jeru, who came up with the idea of working on cancer. And we were surprised because it hadn't occurred to us. What Mercy said, as I recall, was that the importance of cancer and the failings of cancer care had really been shifting up the policy agenda very sharply in Kenya. And what Mercy wanted to do was that she wanted to pick up this opportunity and address it. And she wrote the first draft of this idea, and the Tanzanians immediately also picked it up as important. So it was clearly around in the African policy agendas. And I think it was part of the fact that at that time, African policymakers in health were becoming much more aware of the importance of non-communicable diseases. So the importance of diabetes and cardiovascular disease and the extent to which they were important causes of mortality, particularly for younger people, had become evident in most African epidemiological work. So cancer was part of that shift in perception towards the importance of NCDs. And so we started working as a group, very much including you, picking this up and developing the proposal, which eventually went to the Economic and Social Research Council in the UK.
I remember in the justification, we wrote about cancer being the hard case. And in a way, it strikes me that the kind of researchers we are, where all of us have been taking apart different pieces and trying to see how they fit together, whether it's an industrial organization on the manufacturing side or issues at the interface with hospitals or health personnel, logistics delivery organizations. These somehow don't seem to come together very easily. Health researchers traditionally don't look at the industrial organization of it. And as you very well know, economists don't necessarily do this, and neither do science and technology policy folks. So ICCA seems to be quite unique in that respect. Could you elaborate on that a little bit?
We're unusual in having a long-term trajectory thinking about this. And I think we were interested in cancer as a so-called hard case because it seemed to raise a string of the particularly difficult issues in relation to industry and health relationships, partly because chemotherapy drugs in particular are so expensive. partly because it became clear when we did the background work for the proposal that the import dependence of African countries on cancer-related commodities, supplies, and so on was almost total. And partly because it hadn't been researched. So we thought it was a particularly interesting way to do what you're just talking about, which is to have another go at bringing together innovation, which was clearly crucial if you were going to get anywhere on cancer. Innovation to try and reduce costs, innovation to try and make it possible for local manufacturing to take up some of these challenges, innovation in terms of the ways of researching this, maybe. That case seemed to bring the kind of challenges we wanted. So we thought we'd try. And one of the most innovative things I think that the African colleagues brought to it, and I think it was particularly Mercy again, was to decide that we must interview patients. So that whereas previous work had looked at manufacturers and at health policy people and at people who are delivering healthcare, we had never previously in this work actually gone and talked to patients. That's particularly challenging. It involves quite different ethical issues. It's involved a lot of work on behalf by African colleagues in trying to get the ethical and practical issues resolved. It took us a long time to get going because of that. But it's been absolutely innovative. We've got a completely different view, I think, from where we started, because we've interviewed 450 people with cancer in East Africa. And that, I think, it was a different way to do this. And it's changed the ways in which we've gone about the rest of the project in ways we're still struggling with, I think.
You know, the point you just made, which is that it is different to interview patients for researchers like us, is sort of a kind of a mirror image in health research, which is that while they always talk to patients or often talk to patients, they may rarely be speaking with firms or industry. It really just sits in the backdrop. I want to hand off to one of our team members, Ojasvi Ghai, who will ask you a few more questions on this.
Professor, I think that this project has also been unique because of different countries being involved and the learnings of different countries being shared with each other. So why is it important for a project like this to have multidisciplinary teams with their context of specific research methods coming together and sharing knowledge across boundaries?
I think it's a really good question. We continuously learn a great deal about boundaries and about how we can struggle across them. And I think, there's been, as you've referred both to the cross-country issues, which are necessarily cultural. There have been 4 countries involved. The 2 African countries are very different. They really are culturally. The African and Indian countries are very different in terms of everything from research approach to just history and experience. And the UK researchers are learning all the time, and about ourselves as well as about other people. So I think it's crucial, really. I don't see how you could do this research. I mean, in a way, it's evident that, health and industry, you're going to need multidisciplinary teams. Smita just referred to innovation researchers not necessarily working even with industrial economists, and industrial economists not necessarily working with business experts. Once you then get out into talking about the relationship between manufacturing and health, there are very few people who straddle that boundary. One of the interesting things I think we found when we did the earlier project and what we've built on is that one of the few groups that are forced to straddle the boundary between industry and health are the regulators. And we found when we did the earlier project a lot of interest from the Tanzanian regulators, that was in particular, in terms of trying to understand what we were doing, and in terms of seeing that it might well feed their own needs. Because the regulators are really very, for example, the pharmacists who work in manufacturing regulation for pharmaceuticals, they need both the health understanding and the industrial understanding. And they're pretty much the only group, apart from now, us, who do. So I think we've been cultivating, efforts by health researchers to try to understand industrial data, by industrial researchers who are interested in health, to have found health colleagues who actually want to talk to them for the first time. So that one industrial researcher who I won't cite specifically, but she said at one point that, she'd been looking for this project for 20 years. It was the first chance to really find healthcare people who really wanted to talk to her about industrial development. So I think that's why it's important. I think, though, that even for the health people who've been interested in the industrial work, the interviews with patients have been a revelation, because we were asking patients, specifically what their needs and requirements were in relation to what was available in terms of industrial commodities. And they were very eloquent. Everybody could answer that. And one of the most interesting things I think that's come out of the project that we're absolutely still working on, and I think this would be true in India too. It'll be interesting to see how that comes up in the Indian podcast. In both Tanzania and in Kenya, the initial work on links between industry and health, where it seemed like something early, affordable, and potentially really important could be done, in both countries were in the areas of palliation and survivorship. So that they were about better pain control and about commodities which help with dignity and just going back to work for cancer survivors. And that whole area of palliation and survivorship, I think, has been completely underplayed probably in the world of cancer care, which has tended to be focused on treatment, but very definitely in the much smaller world, which is thinking about industrial inputs to this. So that's been a real process. And all that, I think, really does falls into multidisciplinary work, because the people who interview patients within healthcare are not the same people as those who do prioritization for funding, for example.
If I may ask you, given the current times we live in, what perspectives do you have about local health and global health scenarios?
I think that's a very good question too. I mean, the thing we haven't talked about is the fact that we've been doing this project through a global pandemic. And that has really been an extraordinary trajectory, actually. I mean, it's hard quite to believe that we've managed to do it. I mean, people have worked through loss and illness and enormous stress. So we've been working in that context, but that context has, oddly, also offered opportunities. One of the things that the COVID-19 crisis brought home again, very, very forcibly to African policymakers, was the importance of local supply chains. That what happens when COVID-19 hit was really, for African health systems, an absolutely toxic combination of import dependence, the cutting off of imports, the low purchasing power in foreign exchange that those countries had, which meant that the sharply rising costs of remaining available imports were unaffordable, and at the same time, relatively low manufacturing capabilities. So that had an enormously detrimental effect on healthcare. At the same time, it meant that countries with some manufacturing capability did demonstrate the innovative possibilities. When you have to do something, you can do quite a lot. And countries with somewhat stronger manufacturing, such as South Africa, Kenya, Nigeria, Ghana, came up with a whole range of activities, manufacturing activities to support COVID-19 healthcare that previously hadn't been being done. And they ranged from national scale production of hand sanitizer through producing local PPE, protective equipment, through local ventilator and oxygen supplies, and so on and so on. So it was both a really disastrous experience in terms of the loss of manufacturing inputs and an experience of some of the things that were possible when you have to do it. So what that has done, I think, is it's pushed up the policy agenda, what we've called for a while local health. And it was a phrase that I think we owe to two other African colleagues, Julius Magwagwa and Jeffrey Banda, who coined it. There's an article we jointly wrote on the subject, which is in Health Policy and Planning, where we tried to define what we meant by the importance of local health. What we did was we talked about two aspects of it. One is what was called proximity, which is just that having local supply chains, local producers, the capability of doing effective local registration and regulation, where you're doing interactive regulation with people you know, the scope for local developmental supply chains, if you like, built on proximity. That was one issue. And the other was what it was Jeffrey Banda called positionality, which is the importance of local power and agency within the development of the health industry links. So that the ability, for example, of developing local expertise, local scientific expertise, local innovative capability, and simply local manufacturing depth meant that in crises, you can do more. So I guess what we've been arguing really is that local health and industrial perspectives on things like risk and health security necessarily differ between low and middle income countries on the one hand and high income countries with much deeper manufacturing supply chains on the other. And that local health security really requires local industrialization. And that notion of building local health security collaboratively between manufacturing, regulation, and healthcare is really a building block of global health. It's not in opposition to it, but it's a building block. It's a way of strengthening global health security by recognizing the importance of the local in terms of power, positionality, and proximity. And it's something which was increasingly, before COVID-19, being recognized by the global health community, so that increasingly global health procurement was being rethought to allow, for example, for the importance of local supply chains and so on. So it's not a new thought, but really, I think COVID-19 has focused this as a really important, that local health is really an important building block in the development of global health security overall.
I wanted to pick up on the point about the industrial trajectory, because it is true, Maureen, when we think about our community of researchers and this project, there really is such a different understanding across the countries, particularly during COVID as well, which has exemplified this problem. The capabilities to respond to certain kinds of health problems really do require domestic capabilities of certain kinds. And in India, for example, there really has been this quite long-standing understanding that the health industry has kind of woven in and out of other industrial endeavors. And the attention to sort of the health industry broadly defined allows us to tackle certain kinds of cancer issues, not just in treatment, which was the important point you brought up, but also some of the other issues which might have to do with palliation, survivorship, and early diagnosis, particularly. Could you say a little bit about what you hope to have come out of this? We are still all in the end phase of our research, and perhaps you can tell us a little bit about what, as a primary investigator, you hope will come out of this project.
I think we're all still writing. And one of the exciting things about this is, of course, that I don't know what's going to come out of it. As you know, we're planning to do a book. I know only too well that those books take on a life of their own because we've done one before. And we'll find that we're doing things that we don't anticipate. But I very much hope that what will come out of it is a body of writing and a set of inputs to policy and policy debate, which both influence how cancer care is thought about. Really, I really hope that, and addressed in low and middle income contexts. But also really does pull together, it's one of a series of processes that are pulling industrial researchers and health researchers closer together. And one of the things that's quite close to my heart, I think, is that the industrial research and industrial economics, which are not quite the same thing, but they're interrelated, those two traditions were strong back in the 1960s and 70s in African contexts, and then they somewhat got lost. So that, for example, even now, the African Economic Research Consortium, which does this really excellent networked master's degree in economics, still doesn't have an industrial economics specialism to this day. However, we can hope that will change. And there's absolutely no doubt that industrialization is back on the agenda in African countries, right across the sub-Saharan African subcontinent. And really the health industrial theme, if you like, within that industrialization push has a real platform. So I think it raises some interesting issues that are not traditionally industrialization ones alone, because it raises, and we've talked about this a lot, the general issue about not regarding the big social sectors like health and industry as somehow unproductive, but instead seeing health, for example, as a truly productive sector of economy and society, and integrating that into the way we think about industrialization. And some years ago, I think it was 2014, Paula Tibande-Bage, a social sciences researcher in Tanzania, with whom I personally worked for many years and who, alas, has now died, she and I wrote a paper called Health as a Productive Sector, which was a background to the Tanzanian Health and Development, the Tanzanian UNDP Human Development Report. And it was quite widely discussed, and it argued really just this case, that health is not a drag on the economy. It's part of the economy. It's a productive bit of the economy. And the moment you think about its relationship to industrialization, you can see that very clearly. And I think that argument, that Paula was one of many people who really wanted that to get into policymaking, I think that argument is on the agenda. I think it's still hard. I think the issues that were just raised, that multidisciplinarity is tough, that applies to policymakers who are busy. And they do industry, or they do health, or they do, excuse me, really, you want me to think about both? But actually, yes, I think it is getting onto those agendas. And yeah, I think it's part of an intellectual trajectory that I hope will go on pushing.
We're very grateful to all the support that we've had from ESRC, our respective universities and research institutes. It's been a fun project for all of us to be involved. Maureen, thank you so much for joining us.
It's been a pleasure.
For folks who really are interested in complex research topics and who understand that it takes both patience, tenacity, and a sort of ability to talk across our boundaries, I hope you will all keep tuning in for the ICCA podcasts.
Thank you for listening to the ICCA India podcast. Do follow our social media handles and stay tuned for the next episode.